Welcome to the Heal with Kelly podcast. I'm Kelly Noonan-Gorse, and every week I speak to the leading doctors, healers, spiritual teachers, and scientists to find out what is truly possible when it comes to healing. I also interview real people with extraordinary healing stories. My philosophy is, what's possible for one is possible for all. Thank you for joining me on this beautiful journey of remembering our divine nature and tapping into the truths that shall set us free. Hey everyone, and welcome to the Heal with Kelly podcast. I'm very excited for today's very important episode with Dr. Robert Whitfield.
Yes.
Whitfield. He's America's Breast Implant Illness Expert. He's done thousands of explant surgeries. We call him a world-renowned holistic plastic surgeon certified by the American Board of Plastic Surgery, specializing in breast implant illness, and he's pioneering surgical techniques. His expertise is in oncology and microsurgery, and it distinguishes him as a leader in advanced breast explant procedures and innovative treatments like the no-cut facelift, which I'm going to have to find out more about that at the end of the episode. Dr. Whitfield embodies compassionate surgical care, pioneering a new paradigm where surgical excellence merges seamlessly with holistic healing. His unwavering commitment to transparency and patient-centered innovation continues to redefine the landscape of breast implant illness treatment and surgical recovery, delivering transformative insights and outcomes for patients worldwide. At the heart of Dr. Whitfield's practice is the Strategic Holistic Accelerated Recovery Program, also known as S.H.A.R.P, which this book just came out. I'm so excited. So we're going to dive into it all today. Welcome.
Thank you so much. I really appreciate the opportunity to share our expertise and experience with your audience.
Yeah, thank you. And I have my own personal experience. I'm excited to dive into what mine is, and then we can go from there because I didn't even know, and I don't think a lot of people still know about breast implant illness. We're certainly not educated, when we go to the surgeon to get the surgery.
It's a very complicated thing, and I don't envy practitioners trying to figure it out when they sit across from patients and hear the symptoms.
Yeah. So what are the symptoms? How do you know if you are at risk or have implants in, and what are the symptoms?
So for the audience, my background is in oncology. So from the time I started taking care of cancer patients, your role as a plastic surgeon is usually at the end of a cancer patient's kind of initiation into the process. So they've seen a medical oncologist and or another surgical oncologist and maybe radiation therapy specialist. And then at the end of that, here they come to my office, typically on a Friday afternoon at like 4 after that week, and I'm supposed to explain all the different nuances of what I could do technically to help reconstruct a breast, if that was the case, or a jaw, because I did that as well. Very complicated. I spent many, many hours explaining things to patients so they could, understand and make decisions, knowing full well that like everything was going just in one ear and out the other, because it had been such a complicated, process for them. Yeah. So I didn't spend a lot of time with a lot of young patients because most of my patients were older. And I think that kind of led me down a very specific route of taking care of patients and explaining things in what some people would probably think is, a lot more detail than necessary. But when you're dealing with cancer reconstruction, you have to go into a lot of depth just so the patient can make a decision. So I didn't really do a lot of implant placement for cancer reconstruction. I specialized in a technique that required operating room microscope. So it's called microsurgery. You use suture that's finer than your hair, and you use a microscope to put these things together that look like basically coffee stirrers. So I would take the tissue discarded in a tummy tuck connected to the blood vessels of the abdominal wall, and that's what we would use to reconstruct the breast. And then afterwards, we would do treatments to refine the result, and that's how I have so much experience in fat transfers. So there's a lot of things written on the internet because the internet's undefeated about fat transfers, but most of them are nonsense. So if you look at the course of the care, when we would do cosmetic cases, those patients got the same lengthy consultations that my cancer patients got, and they got the same follow-up my cancer patients received. So I didn't create two pathways for patients. They always had the same path. So I would see patients who had cancer who had been reconstructed with implants come in with different problems, because you're going to have them, because you get more operations, you get more therapies, you have more chance for infections, capsular contractures, all the things that you would associate, or negative outcomes, you would see those more frequently in a cancer population. So I would see those patients and convert their implant-based reconstructions to what's called an autologous, which is using your own tissue reconstruction. I knew, as everybody does, when you take out a foreign body and you take out all the capsular material, you can stop if it's a immunologic reaction from happening, because you're replacing it with their own tissue. So it's like doing a auto transplant. So all the things that they were, we read about and hear about, mast cell activation syndrome and all these things related to histamine release, all that stuff goes away in those patients if that's the genesis, the implant's the genesis.
Wow. And I mean, where to begin? So when you say you're reconstructing breasts with, will you even, knowing what you know about breast implant illness, do you still put implants in?
I haven't put in implants for about 5 years. One, we're so volume challenged now. I've hired another surgeon to help with us, because I usually have about a 6-month waiting list just to either be seen or be operated on. And we have Dr. Chung now, who's been he's a great addition to the clinic, and we have a strong team of over 30 people working for us, helping patients through the recovery programs we have in the office. We have things like hyperbaric oxygen therapy, multiple lymphatic massage devices, and a masseuse, and red light therapy. We have all the things in the office, so it takes quite the team to actually take care of everybody. But the placement of devices, knowing what we know, it's not that I can't, it doesn't make a ton of sense. When I go back to what we used to do in terms of explaining options to patients who wanted to have an enhancement, it would be, can you use your own tissue? Of course, because I knew how to do all the other techniques, I would tell them, if you want like a cup size change, then you can do a fat transfer, provided you have enough fat. If you wanted more than, a cup size, then it's going to be another operation, or it's going to be an implant. And then you have to discuss the risks and benefits of implants. I think what we hear a lot is patients ended up with a larger implant than they wanted, and or they weren't explained all the things that could happen. And like I said initially, I never spoke to a lot of young patients. The youngest cancer patient I ever had was 24. When you're speaking to people about cancer, they're a little bit more attuned to what I'm going to say versus an 18-year-old who really wants to change their body image. They're focused on getting that change, and you're not going to stop them. People ask me if I would let my daughter get implants. It's always the question to me. So my daughter's a Leo, for everybody listening. Leos don't listen to anybody, much less their fathers, much less one like me who has this much understanding of the problem. So if that young woman is focused on that body image issue, there's not anything I'm going to say or do that's going to change them doing that. They'll cobble together money and they'll go get it done. The point is, from my perspective, once you have all the information, then you make the decision. That's an informed decision. I think people would be far less irritated and upset about the process if they made or felt like they made the best informed decision given the information.
Totally agree. I remember my 18-year-old self, and I am an Aries, so I relate to your daughter. So I actually just spoke to, well, I'll get into that in a second. I'll talk about my personal experience, and then you could walk me through, what was going on. So I was 31, I believe. 31. And had always had I was an athlete, and people would always make comments like, oh, are you a swimmer? You've got such broad shoulders. And I'm a little leaner than I was now. I'm a little leaner now than I was then. But so I wanted implants just to be proportionate, and I was a fit model. So was proportionate, I thought, in my perception, warped perception everywhere else. But I was an actress. So I told my surgeon, I don't want a big one. I just want better shape and just a little bit more proportion. So I was probably a B, but they were like not a beautiful B. So I wanted like a full B, small C. And he's like, you're going to regret it. You're always going to want more. People wake up and they wish they had more. I go, I promise you, I'm blonde. If I wake up with more, I will be, pigeonholed into one role. And it's not a role I want to play. So I battled with him and, woke up. And whatever the recovery is, I just remember this like motion where you have to like move them around after you're recovering. And I did it like 10 times what you would normally do because I was just so afraid of them hardening and I wanted really natural boobs. So I chose silicone, even though the risks, what I knew, I was enough aware that there was more risks with silicone than saline. Yeah. But again, when you're doing it for aesthetic purposes, you're just like, whatever, I'm just going to deal with the risks. And I was very healthy. Anyways, boobs were great. And then my one concern was, will I be able to breastfeed? Mm-hmm. And they went in through my nipples. So I was really concerned about that. And ultimately I was able to breastfeed, but I was so big with milk and everything else that something happened. I don't know where along the line, but the right one ruptured and I wasn't aware of it until, so I think I got pregnant like 10 years into the implants. 10 years in, then anyways, one started feeling, after I breastfed and stopped, one started feeling like a little hard, but it still felt soft. But I just noticed it was doing something different. I went to I've never gotten a mammogram before. This is my personal decision. I'm not advocating for this. Everyone I know recommends them, but I go to Sonosine for, this like really high intensity ultrasound. And then if there's a risk, you can follow up with a mammogram, all that stuff. Anyways, she saw that there was probably some ruptures in the right one. And it had been 12 years since I got my implants. I knew they kind of had a shelf life of about 10. So I said, okay, great. Different phase of my life. I no longer want big, big herb boobs. I'm happy to just go au naturel. Within like a month or within like 2 weeks, my friend had introduced me to Dr. Neinstein in New York for something totally unrelated. Like I just wanted to get, like a little Botox or something. And I was in New York and hadn't done it in 6 months. And she was like, I can get you in tomorrow. And then we ended up, a month later, took my boobs out. Full disclosure. But all of that to say, when he opened me up, the right one had fully ruptured. It was like this. And my body had completely encapsulated it. And of course, they had to clean all of that out. But he said my body protected me, 99.9%, which is phenomenal. So I guess, I'd love to know what your theory is on why it ruptured, or, I'd love to and just talk about all the risks, like mold. People don't know that if your implants are in there too long, or if they're maybe mishandled, they develop mold and biofilm. I just want to get into all the risks.
So the patient that changed everything for us in practice came to me in 2016. It was a breast cancer patient who had a breast reconstruction with a silicone gel implant like you're describing, and they wanted to go flat. So instead of a cosmetic patient who just doesn't want implants anymore, there was a cancer patient who wanted to go and basically have a flat closure, which is absolutely within everybody's purview. And so the patient had one symptom. It wasn't something consistent with what you're describing. It was fatigue. A lot of patients suffer from fatigue who have breast implant illness, and a lot of patients who've had breast cancer who got chemotherapy or radiation therapy or take the medications to help reduce the recurrence rates have fatigue. Pretty common in that population. So I took those out, and I fundamentally still do the same two things for each patient I take care of. So I will always take out all the capsular material, because in a cancer case, you want to make sure they don't have recurrent cancer. Mm-hmm. And there are a lot of incidences now with breast implant associated lymphomas and squamous cell carcinomas, and just the prevalence of breast cancer in general. So in my practice, just in the last 6 months, we've had 3 patients have breast cancer. So all that stuff always gets sent off. You always have access to it. It's not some difficult thing. Now, what has changed is from that patient, we found that they had an E. coli infection. Mm. So that was quite shocking, because my sister, who recently passed away from breast cancer, if somebody had missed that on my sister, I'd be supremely pissed off. So I had missed this, and I went back through the notes, and we went, to my nurse and everybody in the clinic was like, "How did we miss this?" And we hadn't missed anything because there were no physical manifestations for this. There was no change in laboratory, so the white blood cell count was normal. She didn't have redness. She didn't have swelling. She didn't have pain. She didn't have a capsular contracture. She didn't have anything that would normally tip you off there was a problem. And this is why I told you I don't envy providers trying to figure this out. Mm-hmm. So I put her on an oral antibiotic to treat E. coli, and magically all of her fatigue went away. It's amazing. So she put me on Facebook as somebody who would do explants in some private group. And then I just had people start calling the office, wanting to have an explant. So my office was like, "What are you doing?" I'm like, "I'm not doing anything. I didn't do anything." So fast forward in 2018, we did all these explants, and we were, gathering, what we felt was some information about this and the symptoms and everything. And then I had a patient come from Louisiana who was a nurse. Her sister lived in Austin, and she wanted to have an explant with me and stay with her sister. So we did her explant, and I took out her implants, and they weren't ruptured, but they felt really slimy. So I thought, they're infected. This is a biofilm, and we'll explain what biofilm is shortly. So I sent them off, and traditional techniques, so for everybody listening, it's like taking a Q-tip and wiping it around in the pocket or on the surface of the implant and sending it off. They put it in a what's called an auger plate, rub it around, and incubate it. That's been done, forever. That's always been the standard. And it came back and said there was absolutely nothing on this implant. And I was like, oh my gosh, that's completely, now I'm really aggravated because I went out, I know there's a problem. I went out and told her spouse, I'm like, she's going to be fine. As soon as I figure out what this is, we'll treat it and be fine. Because of that experience, we switched to what's called, and everybody knows this from the pandemic, a PCR test. So in the pandemic, you can take an antigen test or you can take a PCR test. PCR tests, it's based on DNA fragments. So it'll tell you exactly what's there. So we switched to DNA testing of each capsule specimen, and we've done that since February of 2019. And last week, our paper was published with over 600 consecutive samples setting the incidence, or how often we find bacteria on the capsule, your S.H.A.R.P capsule, not the implant capsule, at 29%. So if you look at my study experience over time, it probably varied between that number 29 and as high as 35. So roughly, if you want to set it like a third, will have bacteria. So the bacteria in my experience is Cutibacterium acnes. In other experiences, it's Staph epi. That would be number 2 on our list. And so in recent papers published that discuss how often it's present, we're going to use our numbers, 29%. And then its interaction with the breast tissue is really going to become what explains why people have symptoms. So the symptoms, for everybody listening, very common symptoms are brain fog. You can have ringing in your ears. You can have just dry eyes, dry mouth, just respiratory symptoms, shortness of breath, like a cough sometimes, difficulty swallowing, muscle aches, joint aches, vibratory symptoms, which seem kind of odd, but they're all based in neurologic inflammation. So you can have nerve pain, which I think some people have had, like shocks will understand nerve pain, or pins and needles if your foot went to sleep. That's nerve pain. Other things that are gut related or related to the reproductive tract or the urinary tract, UTIs that just won't go away, vaginosis that won't go away, GI symptoms like constipation or swelling or bloating, even when someone has a glass of water, they'll have trouble. So this is just a laundry list of symptoms that affects every system in the body, and these symptoms really reflect just chronic inflammation.
And is the bacteria or whatever's like growing locally, whether it's E. coli or what you're finding in the film, is that seeping into the system and causing the inflammation, or is it taking away, it's pulling resources from the immune system so that other stuff is able to sprout up and UTIs, etc.?
So we just interviewed the scientist who laid most of this out. His name is Dr. Mithun Sina, and he's at Indiana University Medical Center, where I happened to train many eons ago. And he's shown
Hoosiers?
that...
Is that Hoosiers?
Yes.
Yeah.
Yes. It's a long time ago. He has shown that the bacteria, the biofilm, the aggregation of bacteria, as they interact with the breast tissue, it helps produce and oxidize molecules called oxylipins. And it's these molecules that interact with you, your immune system, will say it that way, just keep it simple. And that can lead to the symptoms, chronic fatigue, dry eyes. So oxylipins in this situation are the molecules that are acting badly, and they're shown to be higher in patients who are more symptomatic with BII or have these bacteria. So it doesn't explain like everything. It's not like, oh my gosh, this is it, it's all done. But instead of people being gaslit or told they're not experiencing what they know they're experiencing, or it's all in their head, or whatever you've been told, there is an actual scientific basis. Our paper shows that the true incidence is basically 29% on the best available technology you can use to sequence it. And then this paper that I'm discussing with Dr. Sina's shows the molecule that's contributing to the problem by the interaction between your breast tissue and the bacteria. And so that everybody listening, the scar capsule that forms around the implant is not impenetrable. It's not impervious. It's not waterproof.
Oh.
So think of it like a woven fabric. If you pull the fabric and stretch it and then look at it carefully, you can probably see through the fabric, depending on how tightly woven it is. And so that interaction can happen. And just like you're describing with a rupture, now I have had people get really sick after a rupture.
Yeah, I'm shocked. I was not.
Because that interaction between your tissues and that material, like for everybody listening, if you have a rupture and you've been told it's okay, I assure you it's not. There's no way that's okay. That's a failed medical device, and it should be removed. If you were a cancer patient of mine, I would have taken that out. And they are the most highly surveilled patients on earth. So nobody would sit around telling their cancer patient it's okay to leave a ruptured implant in. Certainly not me, who had did that my entire career. We would take them to the operating room and take out all that material that's ruptured. So that more and more evidence that's scientifically based, there's no questioning it, is coming forth. And I'm happy because I feel like I've had quite a big target on my back for a long time now. And it's actually very gratifying for the patients. I'm fine with getting, things thrown at me. But for the patients to like understand it, and we just did a video the other day about it on our YouTube channel to help just explain it better and more easily.
Yeah. So biofilm, 29%, say if there's a rupture and it's, is it bad if saline is seeping into your system? Because they told us it was safer. Is it silicone? What's the percentage of that leakage inflammation problem happening? Poisoning?
Yeah, I'm going to use this to address the TMZ mold thing. So mold is not a thing on implants.
Okay.
So I've looked at thousands of PCR tests on implants, and fungus, which is mold is a fungus, is not a thing. And I think the first 1,000 we looked at, there was 5. So, and those mostly come from people in Houston, just so you know.
Moldy. Moldy
For us, that interaction, if you will, the saline should be sterile as it was placed sterilely in the operating room. And if it deflates, then you had a rupture, and people would call and come in. The thing with silicone, which in 2012-13, silicone was really reintroduced to the marketplace broadly, and a lot of people went straight back to using silicone-filled devices. Now, those devices should have gel. That everybody's heard the concept, gummy bear. So the highly cohesive gel implants, the gel shouldn't go anywhere. Still, if it's ruptured, my advice to you is to get that removed, because that interaction in your body may not serve you. That can really stimulate your immune system. And so everybody listening, I consider breast implant illness to be chronic inflammation and a medical device, in this case a breast implant, is playing a role. It's not the only contributor to this, and we can talk about genetics and gut microbiome and toxicity testing and food sensitivities and metabolomics and all the things mentioned in my book, because those round out and helped us figure out and address many of the other root causes for inflammation affecting the patients.
And also just the fact that it is not a biological, it's not your own tissue, it's being introduced in your body. So it never, like an organ, like a liver transplant, you suppress the immune system so it doesn't reject the organ, and then over time.
I'm glad you brought this
right
up. This is perfect.
Like, do we ever accept the foreign object, or are we always our body fighting to get it out?
So the last surgeon to win a Nobel Prize was Dr. Joseph Murray. He is the person who showed that you can transplant a kidney from one Siamese twin to another. So he executed all the technical steps and shows it was possible. So the next step would be the introduction of immune suppression, because obviously not everybody has a Siamese twin who needs a kidney transplant. So if you gave me your kidney or I gave you my kidney, they'd have to give you drugs to block the immune response. So what I find is people are getting put on little bits of drug to block their immune response. In this case, their immune system is super ramped up now. Nobody knows why. And they're not willing to or versed well enough in immunosuppressive, therapy like you would for a transplant patient. Like, obviously, I took care of a lot of patients who had a lot of problems, and transplants were common where I trained. They would give large amounts of steroids and immunosuppressive medications. And it's not that you want the patient experiencing the inflammation from the implant to have that, but that's the reason why they experience the inflammation. And then when they get methotrexate or prednisone or Plaquenil or whatever else they're getting, it's never going to really stop it. It's more like a little bitty Band-Aid. So they may feel better for a little bit, but it's not enough to really stop the underlying problem.
Mm-hmm. So you just got to get them out.
Yeah, I feel like when I have people come in and they ask me, can you run your program and me keep my implants? I mean, the short answer is no. I have a lot of people show up to me, and just so everybody listening understands, nobody comes to me who, how should I put it? When you come to me, I don't tell you you need an explant. You come to me when you've decided you want to have an explant. I will explain everything about the process and give you all the support with our team, pre-op, with our programs, and we have a detox team for post-op support and pre-op support. So we'll do all that for you. But I think you talk a lot about mindset. I've heard you speak about it, and certainly have experienced things with Dr. Dispenza. And it's really a complicated process for somebody who's not in the right mindset to come in and ask me for something, because I'm not a mental health professional. If you're not in the proper situation from a mindset perspective, or in a relationship where it's going to be supportive for you to do this, then it's not the right time to do that.
Mm-hmm. Copy. So I just had a conversation yesterday, which I think is no mistake. It's wild how the universe works. Very close friend of mine, someone very close to me, got diagnosed with breast cancer in June. Mm-hmm. 3 different pea-sized tumors. I forget the actual type, but she's basically, they're hoping that they could just be done with surgery and not have to do any radiation or chemo. Mm-hmm. And then they kind of talked her out of a double mastectomy because it's only on one side, and that's a really invasive surgery if you get rid of it. So the whole conversation was about, this debate she's having with herself, like, do I just go flat or do I put in a small implant? And sorry, I'm grabbing my boobs all the time. She's a petite woman with, small-ish boobs. So it would just be for, symmetry.
Yes.
And she knows the kind of risks of putting an implant in, but at the same time, she's just weighing those options. So what would you recommend for, what are the options? Just like fat transplant as a safer option, or?
Yeah, so those cases, so for everybody listening, fat transfers, for some reason, recently have been kind of pegged as something that makes cancer detection confusing, which it doesn't. This was all debated many, many years ago, actually in the early 2000s. So like we'll say 2004 until 2010, there's lots of debate about this. And I would present at conferences about this as many others would. And it doesn't affect cancer surveillance, and it doesn't cause cancer recurrence. So the thing will be different based on, like you said, the size of the breast relative to the other breast. And then can you replace something volumetrically with their own fat? So there'll be typically a period of time where you want to surveil someone before you start that whole process. So the options would be like a temporary device, like a tissue expander, converted to a small implant, and then let them wait, or leave the expander in and slowly over time replace that volume with their own fat. So that's an option. And she sounds like she's pretty petite, but even petite patients sometimes who've had children, you can do that operation I mentioned, the DIEP free flap, especially on one side for a small patient. That's an option. So without knowing her, there's, it depends on who you speak to about reconstructive options. And I'll love this because I don't do this anymore. I always was put off by the breast cancer surgeon who said they would explain the options to the patient. Because if you can't do something, you shouldn't explain it.
Right.
I always felt that to be an odd thing. Patients would come to me and say they were told by their breast cancer surgeon to have this. What the fuck would they know about doing that? They don't know anything about doing that operation. So why would you talk about it?
Stay in lane.
I don't talk about radiology. I don't talk about obstetrics. I could, but it's not my game. So I would just have that conversation with her.
What is the DIP flap again?
So it's called the deep inferior epigastric artery perforator flap. And basically it's the skin and fat of the abdomen that are discarded in a tummy tuck.
Got it.
You leave them attached to the blood vessels and use microsurgery to connect and revascularize the tissue.
Wow. Okay. So, but that's a major, obviously, an extra surgery.
You should go speak to somebody who's done many thousands of those, like I've done. And typically they'll be at a center like UCLA, and they'll have done hundreds, thousands of those. So it takes a very good team to do those, but you want the surgeon who's done that, plus all the other things I'm describing, to have the conversation. Because if, all you have is a hammer, the whole world's a nail.
So let's talk about S.H.A.R.P a little bit. Tell me about the Strategic Holistic Accelerated Recovery Program.
Yeah, so everybody, for the longest time was like, what are we going to call this program? And that's a mouthful. But so the program basically is, and I put strategic as the very first word because I think people are reacting too much to what's going on rather than preparing. So if the strategy is to be prepared before you ever go into something, and I know you talked about Peggy's book in your episode when you discussed yours, and that book is great. It's relatively old at this point.
It's so old. But I gave that to my friend who I talked to. But now I have something more to give to her, thank God.
I know. So this book we set out, and it's our collection of really being intentional about how we look at each person. So each person has got a genetic playbook. So if you understand someone's genetics, how they methylate and metabolize vitamin D, their antioxidant pathways, and how they manage glutathione, as well as drug metabolism, and then look at their toxicity burden. So like, y'all, we're in LA today and the air is not great here, and I'm from Austin. It's just hot there. So everybody gets exposed to things based on where they live and the work they do. So we look at that, and that's just through a urine test. That helps build out, how you detox and what are you exposed to. And then looking at gut microbiome health, food sensitivities, metabolomics is a new thing we look at now, measures certain acids in the blood spot analysis. And then we look at hormones. I think people would freak out if they saw how many women have suppressed testosterone, which contributes to libido problems in patients with breast implant illness, because we see it routinely.
Wow.
So for anybody listening who does those shows, we're happy to discuss that. But that's a huge problem.
They're attracting all these other mates with these nice big boobs, and then they don't want to have sex. This is a very big problem.
They have no interest. Well, I mean, it's a common thing because we ask about it because I have people get that done, get the labs done, and we check it, and obviously we know what questions to ask, and they're pretty forthcoming. They're like, nope, not interested. You have to have the hormone balance has, like, it's all about restoring balance. That's basically the program. S.H.A.R.P is about looking at all the things that are making you out of balance to help restore balance, and your air quality, fluid quality, the food quality, stress management, supplementation, all of our supplements that I can make liquid based because I have so many problems with my patients and absorption of food and supplements, and they have constipation, diarrhea, all the things happening all the time when you have inflammation. You have to make it as simple as possible.
Yeah. So someone like me, ruptured, fully encapsulated, but like you said, permeable, so it's probably leached into my system for sure. Do I need to, beyond taking them out almost 2 years ago, do I need to address like detoxing? Like, should I be testing for all the things you test for just to see if there's any tidying up I need?
So I think our program will grow the most because of that aspect of our program, the detox program, because people run my program from all over the United States, and we have people coming from Asia and Europe now, and it's to look at that specifically because some people will explant and not really feel that much better. So despite my patients who get on Instagram and are super happy, like Lauren Bostic, basically from the recovery room, she was creating a leaching situation by going into her sauna. And everybody gets mad at me when I say this, but the degradation of the shell, which has all the heavy metals in it, was going into her system, and we tested it. And then after her explant, she spent the summer in Italy, basically, and then came back and we retested it, and it was all out of her system. Oh. So I would say the short answer is I always want everybody to use that tox test as a benchmark for themselves, because everybody's going to have a different one. Mm-hmm. And we do see people who have elevated levels of tin and cadmium and things, depending on, their level of detox, and you would be surprised, like ruptures and things like that, because that's loss of integrity of the shell of the implant. Yeah. So nobody can refute what's going on there. Like, I get people all the time mad at me for saying things. But when you have a rupture and things are leaking, that device has lost its integrity. So those things will get into your system.
Mm-hmm. Well, two takeaways is don't use the sauna if you have implants, and take them out and go to Italy. Is what I took away from that.
That's right.
Lexi, on the lake. Look online for flights. No, but I definitely went in the sauna the whole time I had implants, mostly infrared. Does that have the same effect?
Oh, I'm surprised somebody hasn't sent me a cease and desist letter from one of those companies. But so the thing with infrared is nobody knows, and the same with all the other barrel saunas, nobody knows. But this is what got everybody pissed at me beforehand. So heat, for whatever reason, obviously, it'll make you, we'll say, detox more. If you already have limited detox capability, you're going to get potentially feeling worse after a session. So I kind of use it as an example of, like, if you do a sauna session, infrared or barrel or whatever, and you feel terrible afterwards, it's probably something you should have a discussion about, because you're probably experiencing what people call a Herxenheimer reaction, where you're exceeding your ability to manage what you're detoxing. And so we just have people pause sauna until I get the explant done for them. And then about 90 days after, our team works with them to resume it and use probably a binder, just so that you're not going to set yourself up for what we think could be a Herxenheimer reaction.
And are you seeing, is our detox pathway, efficiency a genetic thing, or is it just, obviously there's a percentage of people that have detox issues, but then, or is it just like we're so overloaded with toxins that we need to use binders and other things to help out the system?
I think my patients who experience breast implant illness, and this is the next paper we're going to get done, is have more of a challenge from their baseline genetics. Mm-hmm. So about 40% of the population has problems with methylation. That's known now. Everybody's heard of probably MTHFR by now, mm-hmm. and If not, somebody will charge you probably $600 to get it tested, to look at all 4 or 5 of the genes. But we look at about 250 genes, and we use Envision Labs as the vendor because we want to know your drug metabolism. It's one thing to not detox toxins well or not methylate well, but if you don't handle drugs well, which a lot of people are supremely worried about anesthesia and all the medications, and so we look at that to help identify who could experience problems with that as well. So it's obviously your genetics or your playbook, then your environmental situation, your exposures, the food you eat, the air you breathe, the fluid you drink, all contribute to that.
Okay. Yeah, the sauna companies can't be super mad at you because you need to implement them back into the program of detox, right?
I mean, I like using the sauna, but I think superheating something that's a medical device that's not metal is probably not a great plan.
Yeah.
Especially like you describe a rupture. I have patients all the time. They're like, "Oh, I heard your episode with Lauren, so I stopped and I was just doing it all the time and feeling bad." Or we had a very young person just the other day tell us they feel great after sauna. It's a very young person who's had implants a very short period of time. So they're not lifetime devices, so you're listening. And when I explant them, I don't expect anybody to have an epiphany when they wake up in the recovery room and everything's rainbows and unicorns. So there's a lot of work to be done, both through the testing we do and the detox process afterwards. And for the patients who are concerned about drains and antibiotics, we don't use drains and we don't give anybody any additional antibiotics. Probably the 2 most frequently asked questions, as well as you're not going to die under anesthesia. I get asked this all the time. Everybody's petrified of anesthesia, and I can't do them awake. I can't do explants awake, so we don't do that. We do fat transfers awake, but not explants. And so I have a very experienced team that's done several thousand of my cases, and they would take care of my wife or anybody in my family. So we prepare everybody for surgery. So the anxiety about anesthesia and the medications around it, we can answer all those questions. I've done podcasts about them with the president of the group we use for anesthesia, but it's a very safe and very intentional way we go about it. We try to do everything up front to reduce nausea, inflammation, really try to calm the nervous system down because that's a huge deal. And then before somebody ever goes back to have an explant, our anesthesia group provides a nerve block in the pre-op area. And then I do more nerve blocks, during the case. And so when people wake up, they're not having, from an explant procedure, I mean, nothing like you would expect in terms of even an augmentation where everybody's got the implants up by their throat, their muscle hurts, they're swollen, they're like, when's this going to stop? And all the things that associate with that. Our patients don't experience from an explant or an explant in a lift.
Yeah. And I just did like the mindset stuff with Peggy's book.
Yeah.
You're doing all the, biochemical stuff as well. But this book, I mean, as you're describing it, obviously the breast explant / implant illness expert, but this should apply to every surgery and every doctor should implement this protocol. So
we put it together for that and did not call it or name it anything associated with what I'm doing regarding explants, because we feel this should become how you think about prep and recovery from any surgery. And I'm old enough now, I predate the internet. When we were looking things up, we still went to libraries and there were books, and the actual journals would be on little discs. If anybody listening is old enough to remember what a disc is. The thing now is the genome project's been completed, and really genetics are definitely the pathway to how disease processes can be affected more aggressively and effectively. And if you just listen to someone talk long enough in a consultation with us, you'll understand their genetics pretty clearly. So I've went away from listening to make a diagnosis on a disease to just listening to understand how someone detoxes. And then I hear the symptoms all the time. So it's not that I'm establishing, you have breast implant illness or you had this wrong or that wrong. Like, how do you detox? What are your exposures? Does your gut work or not work? Do you know how to eat or not know how to eat? Like, don't eat gluten, don't eat dairy, don't eat seed oils. Those are like basic things. When you come to see me, if you're eating that stuff, you haven't listened to anything I talk about, because those things all create more inflammation. So y'all have in LA, you have Erewhon and Matu. We have in Austin, we have The Well and a place called DIEP. They're seed oil free. So you have to be very careful about what you put in your body if you want it to perform.
Okay. I got to clean some things up after. I thought I was healthy, but yeah. All right. Can you just give me, anesthesia? Like, do you recommend that part of the detox post-surgery is to get the anesthesia out of your system too, right? Because I know some people that kind of got on the plastic surgery train, and then she got, like, one surgeon screwed it up, and then she's on like 4 or 5 surgeries within a year and a half, like major surgeries. I'm like, this cannot be good as far as anesthesia goes in their system.
I mean, that's a problem. And I think programmatically what we look for and why people will get stuck, like they'll get stuck and have difficulties, not from technical aspects of surgeries, but recovery. We'll just speak about recovery. If somebody's having difficulty with that, your liver dictates much of this. And many of the people who have blood tests come in and say, oh, my blood tests are all normal. Do you know how bad your blood tests have to be to reflect liver dysfunction or problems? I mean, awful. So it's such a huge organ. It's responsible for taking care of and filtering all these things we get exposed to. But what we look at when we look at functional medicine testing, or we look at toxicity testing like I'm describing, I want to see like what is in there. And we have a ton of problems with people getting parasitic exposures now. Parasites hang out in your liver. We have all these different things with glyphosates. Glyphosates are the herbicides, pesticides on foods. And then phthalates, like anybody drinking out of plastic water bottles. Thank goodness everything's glass here. Don't drink out of a plastic water bottle. I mean, it's not good for you. So the phthalates in there are what contribute to hormone problems. And so the number one thing that will go off when you have inflammatory symptoms as a woman, chronic inflammation symptoms, is your thyroid. And how many patients of mine come in with Hashimoto's, or that's the diagnosis, and everybody's concerned about the devices causing autoimmunity issues. So autoimmune diseases predate implants. Autoimmune diseases have been around since the late 1800s. Implants were placed first time in 1962 in Houston. So I think it's more about like, all right, what are we doing in addition to everything else? You know, the implant plays a role, but all those things I mentioned, all these things I describe in preparation using the S.H.A.R.P method, are to just diminish your toxic burden and lower your inflammation through proper supplementation, proper nutrition, hydration, and then certainly if we're going to operate on somebody, we want to help get the nervous system, everything as calm as possible, just like you mentioned using Peggy's book.
I mean, how do we get this in the hands of every surgeon out there?
Oh, the surgeons are going to be slow adopters, but you women and everybody listening can take control of your own destiny by getting the book and reading the book, because I wrote it so everybody can understand it. It is not a complicated book. It is not thick like a textbook. She'll hold it up. It's very thin, very easy. You can listen to it, download. It's not hard to read. And as long as you better understand your playbook through genetic testing, you can access these other tests either through my clinic or other clinics that provide this. You can take more control of the situation for yourself and advocate for yourself. Yeah.
And that's like when you have this information that's empowering you and you can become your own advocate, you just have more awareness when you're interviewing a surgeon to know if they're on your wavelength or not, because you're asking questions guided by this. And if they're standoffish or don't have time or not even open to having that conversation, find another surgeon. Like my guy in New York, I just came in with like the Peggy stuff and like, you know, writing down the statements that the anesthesiologist or the surgeon says to you as you're going under. So you're programming the subconscious mind to say that the surgery is going to go smoothly and there's going to be, you know, no need for drains and whatever it was that I did. And they were open to doing that, especially the surgeon. I was like, okay, so he doesn't, and now he wants me to create like just a checklist for to hand out to his people. Obviously,
that's the checklist.
This is the checklist, but just on the mindset side too. So, is there anything mindset-y in here?
I talk about it. I mean, I think the biggest thing, like you speak about energy in one of your shows, and you can tell when somebody's just got really bad energy when they come into the office. And my team is very good at warning me about that. And so I try to help people understand, like, I am not going to correct your energy by doing surgery. That's something you have. Like, if you need to go to EDMR therapy, that's fine, but you need to do that before you come do this. If you guys are interviewing surgeons and the surgeon is not comfortable with what you're asking them, so let's talk about safety for a minute. Like, there's this big thing about doing an explant and taking out capsule and it being safe. If they tell you it's not safe, you should directly turn around and leave that office. That person is not experienced enough to have a discussion with you about surgery, because there is not a safety issue with anybody with the level of experience that took care of Danica Patrick, like my friend Dr. Parsons, or myself, who's done thousands of cancer surgeries and chest wall reconstruction and everything else. So never make anybody do something they're not comfortable with who's a surgeon. Don't. If they're uncomfortable, just leave.
To be on their table.
And if they're not interested in, you don't really need to get further down the road, right? You don't need to have the discussion. I'm tired of hearing people say that it's dangerous. It's not dangerous. So for everybody listening, in the first 1,000 of these, I had a handful, like 4 or 5, where we exposed the lung tissue by just the scarring of the device. And we repaired it. Nobody went to the hospital. Nobody had anything else go on because I know how to take care of it. Like, that's part of doing reconstructive surgery. It's not anything to get excited about. The thing is, like, for some reason, there's this unfortunate, like, negative momentum. Like, if someone says, I'm just going to take your implant out, having known what I just told you about the publication that came out and what the other publication shows about oxylipin, does that make a lot of sense? Because the biofilm is not going to come out with the implant. When we send samples out, we don't send the implant samples. We send your scar tissue sample. So if you leave the scar tissue in, but took the implant out, then the biofilm or the bacterial colonization is still going to be there. And that's why I have people call me who now want me to take their capsules out after they had an explant. And the explant was done in the office under local and Pronox.
Hey.
And like, okay, well, and the goal was what? There's a famous person here in town who had a problem. And I think a lot of things get blamed on other, oh God, we're going to cause trouble now, other drugs. And there may be things like Botox, or they may be a vaccination, or there may be something else that's immune stimulating. And they'll have an explant, meaning they'll have their implants removed, just to see if that's going to change the paradigm. But right. So for everybody listening, if you don't take out the capsule that has the bacterial contamination on it, you're really not solving the problem.
Right.
If that makes sense.
You're explanting, but you're not cleaning and taking everything that it caused and to grow or whatever.
And you would have no idea about that if you never checked it.
Yeah.
Which nobody doing that in the office under laughing gas would ever do.
So when you're so you need to go to someone that's experienced and you need to ask that, like, make sure that's.
Let's qualify the problem. So 2.2 million women get implants placed around the world annually. I usually see them about 10 years out, and we'll say 30% have the problem. That's 6.6 billion people around the world. And I would say Europe and Asia are at least 10 years behind us in understanding the problem, based on what I see in my interactions. And so it's taking a long time in our country, and we should be leading, not following in the space. And my paper and then Dr. Sina's paper and other forthcoming papers are going to really, I hope, ramp up the scientific understanding of it. So there's not this questioning about how we should be doing and taking care of this for the patients.
Okay. Thank you. Well, thank you for your work, and thank you for creating this. And like I said, everybody listening, if you know anybody having any type of surgery, boob or not, everybody needs to read this book. I can firsthand know that when I intentionally prepared my body and my mind for surgery, I recovered like they were shocked at how, and it was because I did lymphatic drainage. I did all the things, and you lay it out for us so that we are empowered to prep and recover and detox and, really get to the root and remove it. No matter what surgery you're getting to remove something.
It's a very hard journey. So we've created long form content. I have a podcast about breast implant illness and explant surgery. And then on our YouTube channel, we discuss all of this. And I lay out videos for the papers. I try to go over them and explain them because scientific papers are hard to understand. Sometimes I read them and go, ugh, it's a little complicated.
Yeah.
So I make a video about them to try to explain them in layman's terms, what is being said in the paper and how does it impact the patients so that they can understand it. And when they go into their surgeons, there shouldn't be this kind of back and forth.
Yeah.
The patients and the surgeons can read and they can have a communication about expectations.
Yeah. Is there any, just because I know, people that have had their kids and they've been flat all their life, or they've had children and they, the boobs are gone from all the breastfeeding, and so they've recently gotten implants, and it's just made them feel so much more confident, or
Sure.
Is there anything that you could tell people, like, you made the plunge, they're in your body, you got another 8 years left in you or whatever, what is the way to optimize or at least make sure that you stay as healthy as possible or monitor?
So using the methodology in S.H.A.R.P, it's really about understanding your genetics and your toxicities, because everybody has them. Doesn't really matter, depending on where you live, the work you do, your home. Homes are a huge source of mold. We face it a lot in Texas. So you just have to be aware. And then you can start working on things. I do caution people to do more supervised detox in a manner, not do aggressive detox with implants in place, because it can be more challenging for them. So I'm really careful about that with patients, but running the program short of doing aggressive detox, that will help them. I mean, and we want to put out a paper soon about genetics that highlights like the genetic predispositions for this, and we'll get that done in my spare time at some point.
Amazing. Well, again, knowing what I know and knowing my experience, I wish I had met you years ago, but so grateful for your work and what you're doing to help, so many women heal and just drive awareness about this massive issue in our country. And where can people find all these amazing resources?
So we've really aggregated all the resources on YouTube now. It ends up being the easiest for people to access either on their TVs or on their phones. So go to our channel on YouTube and look for Dr. Robert Whitfield. And then we have a podcast just about explant surgery and breast implant illness.
Awesome. Well, thank you. And everybody, it's out now. Pick up S.H.A.R.P. I'm telling you, it's a game changer. And it will be for so many people. I'm so excited to share this with so many people. So thank you so much for coming.
Thank you for having me on.
Nice to meet you. Thank you for listening to the Heal with Kelly podcast. Be sure to tune in every Thursday for more empowering wisdom and inspiring healing stories. And make sure you hit the follow button on Apple, Spotify, or wherever you get your podcasts so you don't miss that one episode that holds the answer you've been searching for. Oh, and if you found this episode inspiring, please rate, review, and share Heal with Kelly so that we can grow our audience and reach more people. We truly appreciate it. Lots of love.